Charles. Hello? Sorry. Okay, we're going to go ahead and get started again. Hi, my name is Jeanette Polchek, and I have the pleasure of introducing Dana Alexander. Dana Alexander brings more than 25 years of healthcare system and executive management experience to GE Healthcare IT Solutions. Her past and current experiences have included academic, IDN, and community hospitals with responsibilities that span the care continuum to include long-term care, post-acute care, home health, hospice, and other specialty services. As an advocate for retooling U.S. healthcare to achieve the goals of the National Quality Strategy and the triple aim of better health, affordable care, and healthier communities, Ms. Alexander is engaged with breakthrough initiatives to support new models of care across care settings to include engaging patients as partners in their care. As Chief Nursing Officer, she guides nursing strategy across all GE healthcare businesses to achieve the company's vision of transforming healthcare and creating high-performance healthcare organizations. She actively participates and represents leadership roles in a number of professional and industry organizations that includes HIMSS board member, HIMSS Nursing Informatics Committee and Public Policy Liaison, the AMIA Public Health Chairperson, the American Academy of Nursing Fellow, and many other national initiatives. She has contributed to healthcare, nursing, and the informatics field through support of research and numerous presentations and publications. Help me to welcome Dana.
Well, it's great to be here. Let's do a sound check. Can you hear me okay? Up? Oh. It should be hooked up, maybe. How's that sound? Now better? Yes? Need both? Okay, we can do both. It's not a problem. Okay, are we good there? Great, good.
You're good.
Well, it's a pleasure to be here today, and I'm going to present to you something a little bit different. I know that many of us are focused with our EHR implementations and heads down with meaningful use, and all of that is very, very important. But there are a lot of other industry initiatives that are going on that probably you've heard of, I know in your working days, but sometimes not really knowing some of the specifics of that or how it connects with the work that you are doing today. So this is going to be my attempt to raise some awareness and really to put onto your radar screen some of these national initiatives. I guess it was about actually the beginning of 2011, and in addition to some of my normal, typical job activities, whatever that might be that always seems to be expanding, is that I also took on the role for AMIA, for the Nursing Informatics Working Group, as chair of the Public Policy Committee. And I can tell you in 2011, within about a 10-month span, we probably gave response to AMIA for NPRMs and other public response documents, probably no less than 13 NPRMs within a 10-month period. In addition, in the beginning of 2011, on behalf of GE as an industry member with the National Quality Forum, I took on the role as the voting member for GE as well. Once again, was not really clear in terms of what I was stepping into. It almost was daunting at times in terms of the number of initiatives and that NQF is really overseeing as a convener along with the other industry and public policy initiatives as well. So to that end, I found that I was having to try to kind of map some of these different initiatives so I could sort of make sense of them and keep them organized some way. So I'm sure that for many of you, you have felt that way as well with some of the terms like the National Priorities Partnership, Partnership for Patients, and I will be reviewing some of those, and hopefully this will help bring some clarity. Again, I probably have too much information that I want to impart with you in the next hour, so pardon me for that, but you will have the slides. I've tried to incorporate a lot of links so you have that as reference material. And that please, if you can repurpose these slides or use the materials in any way for further, I think, investigation and analysis or reference on your part, I encourage you to do so. So with that, I guess tighten your seatbelt and let's go. Let's see, that didn't change. What's this one? Well, may need an AV person here. Oh, there we go. All right. So I think it, in the spirit of evolution, which we really didn't connect on this before today, is that I think it's fair to say that in today's health in our society, that we are a society that is really supersized, and not only that, we want to have it our way as well. That has resulted in some unhealthy lifestyle behaviors that has really added, I think, to the cost burden here in the United States as related to health, not achieving the best of healthy lifestyles, prevention and wellness, and increasing again the costs. So what we are in the midst of then is that healthcare is really undergoing some major changes. We are, I think, experiencing this balance of power shifting from doctors to patients, where patients are not only, and consumers are not only becoming more engaged in their healthcare, they are demanding that they are more engaged in their healthcare, as it should be. We are also seeing pay for performance and government's role in that, in shifting from a volume-based reimbursement and payment system to a value-based, and that we're understanding that connectivity is very crucial to realizing this full potential of really true care coordination and managing care across the care continuums and various care settings. And that in order to do so, that the value of data becomes very critical as well, and will continue to be an emphasis as we move forward. So I feel very compelled these days as I begin presentations and discussion to really start the conversation from the perspective of the National Quality Strategy, because that is really why we are all here, and why, again, on any given day, when we're so heads down with meaningful use in our EHR implementations, and particularly with meaningful use within itself is not the reason why we are dealing with all of this chaos and complexity. It is trying to achieve the goals in the National Quality Strategy of better care, healthier communities, and affordable care, and really engaging our patients and consumers as we move forward. As related to consumerism, then even that, again, the government has really gotten on board with this as well too, and there's the healthcare.gov website that is an attempt to keep consumers and patients informed about what is going on with healthcare reform, to get them engaged, to understand. We have Hospital Compare that is also available now to consumers and patients for comparison of quality for providers and provider organizations. And although that may be rudimentary in various many ways right now, I think it's a sign of the times that we will see that there will be refinement with Hospital Compare, and that there will be, again, more data available to consumers and patients so that they are able to do their own research in terms of providers and provider organizations. So with this big focus on consumerism as well, I mean, HIMSS has also really joined the ranks of that as well. We had the ONC that launched last year, putting the I in healthcare IT, which again is an initiative where people and organizations came to pledge, such as HIMSS did, in terms of making that pledge to developing strategies that would allow consumers and patients to leverage technologies such as personal health records so that they could participate within their care. So again, I think we'll be seeing more of this in the future. Regarding meaningful use, I think the 5 goals and the stages of meaningful use, is something that is very familiar with us today. I think that my point here in bringing up the slide is that particularly for the informaticians and the clinicians in the room, is that we have to continue to look at how are we actually integrating the requirements for meaningful use into our practice and making this a part of our practice in the delivery of care. Meaningful use stage 1 came with its issues, as would be expected with any major change, and it was definitely a major change for us. This is not an exhaustive list, but some of the issues that I think that I have identified and heard along the way in terms of the complexity and uncertainty about some of the meaningful use requirements, the lack of unity that we have felt sometimes between ONC and CMS, certification issues, the need for further public health reporting and bringing in public health reporting, concern with stage 2 timelines, which of course now has been pushed out, and then the quality measures uncertainty, knowing that quality measurement is going to become more and more important over time as we move further along in the stages where we're truly trying to monitor and achieve improved patient outcomes. But that said, is that we are advancing and that providers and provider organizations are getting paid under the EHR incentive program. And these are actually number of providers and payouts from inception in 2011 until March of 2012. So for a grand total of about $4.4 billion, which is actually a bit behind in terms of where CMS was expecting an ONC for payouts. But I think that probably speaks to some of the issues that we've experienced in meaningful use stage 1 and some of the learnings that have occurred, again, that would be expected with such a major change that meaningful use has brought to us. So we also stand now 3 days away from the response for meaningful use stage 2 in the NPRM for CMS and ONC. And I'm sure many of you in this room have been involved, whether in your provider organizations, your employers, or with other industry groups, in providing review and response of these NPRMs. Overall, the stage 2 addressed an extension of stage 1, meaningful use, also some criteria changes, proposed Medicaid policy changes, Medicare payment adjustment exceptions, along with the overview of stage 2 and stage 2 clinical quality measures, which I think has really caused a lot of review, and there'll be a lot of comments as related to clinical quality measures. Again, HIMSS has been very organized as it typically does in terms of gathering the input from its membership, organizing around the review and analysis of stage 2 and preparing response. And I can tell you that response has been prepared and has been sent now to the board for final approval to meet the deadline come this Monday, May the 7th. In meaningful use stage 2, as related to quality measures, while the number of quality measures overall was not increased, what we really have seen in the stage 2 is a shifting from menu to core, where more measures will be required, but really addressing and connecting those measures that are included to the 6 domains of care that align very clearly with the national priorities that have been established through the National Quality Strategy. And we'll be speaking about those a little bit more later on in the presentation. In fact, let me just go ahead and switch here to quality now. So we know that quality and performance measurement is going to become more and more of a focus of ours, in the future, and that it's not something that's going to go away, and it's really going to become, I think, a driver and framing a lot of our work as we move forward. There's, this movement from a volume-based to value-based payment, and so if we're moving towards value, how are we going to measure that? And we need the right quality measures as those reimbursement models change. Accountable care and payment and overall payment reform, again, a real drive for public and private sector alignment like we've never seen before. And particularly for CMS, this is very different in terms of engaging private sectors and sectors, outside of some of the government ranks to really engage in defining the different models of care, models of payment as well. And then quality measures as a direct linkage to patient safety and spending levels as well. And a continued focus then on EHR-based measurement and reporting will be, I think, very critical as we move forward. As related to the National Quality Forum, and I will be speaking about some of their specific initiatives and activities and projects because their level of engagement and involvement seems to just continue to grow. HIMSS has also now providing out on its website a resource to keep its membership informed and abreast about what are the various National Quality Forum initiatives. We'll be talking about the National Quality Strategy, the MAP group, the MPP, and the Partnership for Patients. So whenever, again, that NQF offers webinars on some of these various initiatives to the public or requesting for public comment on documents, HIMSS is posting all of this information out on this particular website. Or again, you can also access through the National Quality Forum as well. But it's a way, again, to think that HIMSS is trying to keep its membership informed about these various quality initiatives, which again, there is a lot, and it can really feel daunting on any given day. So let's just step back and pause for a moment in terms of ground ourselves about the National Quality Forum, because it may be more familiar to some of you than others. The NQF has really a three-part mission. One is about building consensus on national priorities and goals for performance improvement, endorsing national consensus standards for measuring public reporting on performance, and probably an area with NQF-endorsed measures that more of you are familiar with, and then promoting the attainment of the national goals through education and outreach programs. This is all realized to us through really three major ways. One, reporting through government entities. That government entities use NQF-endorsed measures, such as CMS. Hospital Compare uses some of those measures. And states requiring reporting of adverse events as well, too. Those are just a few. There's multiple venues in terms of other agencies and registries using NQF-endorsed measures for reporting as well. Also then, from an incentives perspective, is that again, Medicare and health plans, private health plans as well, use NQF-endorsed measures to align with payment for performance. And this is an area that we can expect, and particularly with meaningful use, or I should say accountable care, that we will continue to see continued emphasis and growth, and I think defining measures in this area. And then I think very importantly, and is informing practice. And as a clinician, and trying to achieve goals and outcomes for patient care, this is where I think it's very important as well. And again, how providers then can translate measures into the practice to truly improve quality of care and safety and achieve standardization based upon the evidence along the way. I also just want to do a quick review as well, too, because we'll hear HHS and CMS and ONC, and so how does that all kind of fit together? So the key agencies of HHS, HHS being really the umbrella organization, is CMS, the ONC, FDA, CDC, AHRQ, and NIH. We probably in the healthcare IT arena deal mostly with ONC from a policy and standards and certification perspective, and then CMS as related to incentive payment and meaningful use, okay? So as related to NQF in terms of its projects and its activities that it takes on is often contracted through HHS or one of HHS's agencies. So the contract and the funding for these initiatives come from HHS agencies to NQF, such as I have listed here, the National Priorities Partnership, the Quality Strategy, and we'll be talking about these here in a moment. As related to the National Quality Strategy, this was under the auspice of the National Priorities Partnership, which was convened by NQF, again under contract with HHS. So our National Quality Strategy was released, I think, early 2011. Before that time, we did not formally in this country have a true National Quality Strategy that addressed then this three-part aim: better care, healthier communities, and affordable care. So again, I've listed the web link here. Additionally, the National Priorities Partnership, as part of their overall efforts in developing the National Quality Strategy, outlined initially 6 priorities: patient and family engagement, population health, safety, care coordination, palliative and end-of-life care, and overuse. And then within the past year, equitable access and infrastructure was added as well too. Hopefully you can begin to see that the correlation now that starts to happen as related to meaningful use, that the 5 broad goals of meaningful use are actually driven then from the National Priorities Partnership and the priorities set forth under the National Quality Strategy. So again, I think important to be able to connect the dots, that there actually is alignment in all of these various initiatives. And yet, another initiative that was launched is the Partnership for Patients. And sometimes you will see as capital P, little f, capital P. Not to be confused with P4P, the numeral 4P, which is, pay for performance. So the Partnership for Patients, again, under the auspice of the National Quality Forum, is a public-private partnership, as MPP is a public-private partnership, but with very specific goals to achieve around patient safety, okay, and improving health care. There are 2 of these specific goals that the Partnership for Patients has as related to decreasing hospital-acquired conditions, okay, and preventable complications during transitions of care, and then hospital readmissions. So again, a lot of work that has been occurring over the past year or so with the Partnership for Patients. I've actually taken an opportunity to attend some of these public meetings. Either you can attend remotely or in person. It is comprised of not only providers, organizations such as the AMA, the ANA, but also payer groups, labor unions, other organizations such as the Diabetics Association. I mean, all various type, again, of public and private entities, and looking at how do we need to improve healthcare with these specific goals that have been set forth. As a result of some of the work of this group is that we now have before us, actually was released a few weeks ago from HHS and Kathleen Sebelius, about a national plan for reducing hospital-acquired conditions. So that is out there for your read and also for public comment as well. So, yet another group that I want to put in front of you as well, that is really starting to gain a lot of traction. And I had my questions about this at first. The Measure Application Partnership, or better known as the MAP. So in 2010, Health and Human Services requested NQF to put together an initiative, resources in the right group, to really give input on a framework and recommendations for setting priorities and goals for the National Quality Strategy. And some of the questions initially as this group was put together and launched was, well, how does this differ from the National Priorities Partnership? I mean, are they not doing some of the same things? Well, the answer to that was that National Priorities Partnership was more functioning at a strategy level for those 8 priorities that I listed earlier on the slide. And the Measure Application Partnership would be getting more into the weeds in terms of specific measures and quality measure groups that are needed to support really achieving the priorities of the National Quality Strategy. So it was established with this following framework of that there was a coordinating committee out there, and then there was work groups set up, work group focusing on a hospital, inpatient side, clinician work group, which was really focused on physician practices, ambulatory setting, the post-acute and long-term care work group, and dual eligible beneficiaries work group, because again, Medicare, Medicaid, dual eligibles are high utilizers of our healthcare system and tend to be, are very costly to our system. In addition, there was another group that was added on, and that was the Ad Hoc Patient Safety Work Group, because of this emphasis on hospital readmissions and hospital-acquired conditions and infections. So the individuals that were nominated for the hospital work group were also then on the ad hoc for the hospital, for the safety work group as well. So again, this was nominations that was put out there publicly across the United States, and could be sent in. You could either, you as an individual could send in your nomination, or through your respective employer or whatever representing organization. Are there any people here in the room that are either on the committee or a member of any of the work groups? Okay. Well, maybe some of you have, taken the opportunity to attend, again, as a public member, just to some of the work group meetings or committee members. I know I've done that on a few occasions. I will say, I think this kind of got off to a rough start. I think the goals, the goals and the objectives were not completely clear, and there was that bit of, storming, forming, and norming that was going on. But overall, this MAP group has really gained, I think, a lot of traction and starting to really to show some really true deliverable and values. So what happened in the fall of last year is that there were several reports, one from each of the groups that I have listed here that went to HHS. There was also a report then on hospital readmissions that was sent out, a report that was sent out on coordination strategy for clinician performance improvement, and then another report that was sent out on the strategic approach to performance improvement for the dual eligibles. Okay, so all of those went to HHS. Then early December of last year, CMS sent 360 some quality measures to the MAP group, and again, asking the MAP group to please review these measures in terms of their alignment and how appropriate these measures were for aligning with the national priorities through the National Quality Strategy. And oh, by the way, we needed this back by February the 1st. So you can imagine that here it is December, holidays are upon us, and these work groups now are faced, of course they were divided up amongst the various work groups, although some of the measures were cross-cutting. We would expect that, so we had multiple groups looking at the same measure to determine really the priorities and the appropriateness of those measures. I wasn't quite for sure how that work was going to get done, but it did. It did, and my hats off and compliments to all of the individuals that are members of these various work groups. So that's kind of where we are here today with the MAP group. CMS then is taking and looking at those measures and looking at, again, where those measures are going to feed into their various quality reporting and performance programs. Now, this slide, actually, I just was able to obtain this slide last week at a meeting with the NQF on the e-collaborative session that we had, and Dr. Kate Goodrich from CMS actually reported a State of the Union with CMS as related to quality and reporting and eMeasures. So this was a good snapshot view for me. I don't think I was fully aware of all the various quality reporting and performance programs under the auspice of CMS, and I think is a good reference for all of us to have. What also Dr. Goodrich from CMS presented too is that this is where CMS is focusing as related to priorities for measured domains. No surprise, it aligns very clearly then with the National Quality Strategy and the priorities set forth in the National Quality Strategy. Now, where we are today with so many of our quality measures, those that are NQF endorsed or not, is that we have measures that are structure measures, process measures, and then those that are outcomes. CMS clearly has, stated, and Dr. Goodrich stated, is that it is the goal of CMS to move more towards outcomes measures in the future, because currently we are very heavily weighted with process measures. Not that that is not good. We're not expecting to totally eliminate all structure and process measures, but we need to be more balanced about truly achieving outcomes measures and to really support, those goals around accountable care in the future. So now I'm just going to take just a pause here and give you a very short story about eMeasures. And I would assume that many of you are involved with quality measures and trying to whether in your as a provider or in the hospital organizations, trying to capture measures and data from your EHR within the context of clinician workflow, and then being able to report on this measure as well. And it has been a struggle, and it's been a challenge, and there's still a lot more work to do. However, there's light at the end of the tunnels that we are actually making progress. So I have to just disclose here, I did take some of these slides and this storyline actually from Jacob Reiter, who presented a few months ago, again at an eCollaborative and eMeasures forum with the National Quality Forum, but I thought it kind of told the story well. So we think about, we have, over 600 NQF endorsed measures. And, particularly thinking about 2 years ago, good measures, great quality measures, but they were all on paper. And so we have our developers, our vendors, and our providers as our three of our main characters for this story. So developers were asking, vendors, why aren't you using these measures in your EHRs, to work with the providers to capture the data and help to report out on? Well, the vendors, have some answers to that. And there's, several different, I think, challenges with, again, the paper measures and consuming them into the EHR. And I'm sure some of these you live with too. Non-standard terms, on that there was not a standardization among some of the terms. Some of the terms were not in discrete values. Not all of the information could even maybe be found in the EHR. It might be found in other places. The logic was also elusive. Meaning that it didn't necessarily, coming from paper to the electronic, that it didn't really follow with the clinician workflow, and it could actually be disrupted to the clinician workflow. And so that there needed to be some work on the logic of what is the measure truly trying to achieve now in an electronic environment. And then, of course, too, that the measure, being that it was prose and it was on paper, was like trying to take a square peg and fit it into a round hole. So with the help of HL7 and NQF and many other various stakeholders, is that the group got together and developed what we have now today as the Health Quality Measures format as part of the retooling process. So that in itself, though, was only a piece of, and a huge piece, however, but to create the standardization and then the right interpretation and trying to convert the paper measures into eMeasures. In addition, the other initiatives under, again, the auspice of the National Quality Forum through contract with HHS was the development of the quality data model. And this, again, the quality data model provides a structure, or really the grammar, for defining quality measures in a very standardized format, so that measures can be expressed consistently and uniformly of all the clinical concepts that is trying to be achieved. In addition, so the quality data model is actually a model that can be used by developers, the vendors, and the providers. The measure authoring tool, which was released last year, is a web-based application that is primarily used by the developers to create the eMeasures without writing in XML. And then in addition as well too, last year, the National Quality Forum released the Quality Positioning System, which is a navigation system, so to speak, where any of us can go out and look to find endorsed measures either by the name, by the number, if we want to also look by the developer. There's all different ways to search these measures, and is really, I think, going to prove itself to be very helpful, particularly for measure developers, where they're trying to look at cross-cutting measures or measures between different measure development groups to see if there's redundancy. And again, a lot of push in the industry, and you've probably started to hear about harmonizing. We have to harmonize, we have to align, because we're creating these redundancies and these complexities, and it becomes such a burden then, particularly for the provider organizations, where they're having to report out on a very similar measure concept, but have to report to a different timeline or report it out in a different way when it actually could be done very similar as well. So I think a lot of opportunity to improve in those areas, but I think we're capturing the attention of the industry to say we've got to do a better job of this. We've got to get more standardized in our development, the way we consume it within our EHRs, and the way that we're implementing it with our providers, and then the way we are reporting it as well too through the various registries into CMS. So as a part of this overall process then of eMeasure migration in healthcare IT, again, it's not the most ideal situation for the 600 plus, currently NQF endorsed measures, where we have achieved over 100, it was about a year ago, about 100, a little over 100 measures that were retooled to eMeasures, primarily in the ambulatory physician, physician office space. Now, we have realized several challenges in that area, and again, I think many of you have realized those with meaningful use, is that the retooling, it really became more about speed to delivery, and there have been some issues around the retooling of those measures. Again, a learning process where the logic didn't always flow like it should, the numerators and denominators really were not stated correctly, and some other just, I think, general kind of ambiguity along the way as well. At this point, what CMS is doing is for the remaining measures to be retooled, if they are to be retooled, if they align again with the national priority strategy, is that CMS is contracting out with other subcontractors, as CMS will do, to do the necessary retooling. So I have to say, standing here today, I don't know exactly where that stands. I know the work is going on. I just don't know exactly where we are in the work. In addition, through the NQF consensus development process, where again, measures are brought forth, and if they are NQF endorsed, then every 3 years they are put up for maintenance review. And then during that maintenance review, like if it was for care coordination or if they were measures that were focused on a specific care area or care such as cardiology, there's also a call for new measures as well. Or the developers can say that this measure is not applicable anymore and we're going to look at retiring this measure. So as these measures are coming forth, there is not a requirement here today that all measures must be written to eMeasure specification, but I can tell you that is, I think, soon incoming. The challenge is that we're living still in both worlds. We have to have measures that accommodate the manual paper world and measures then that accommodates the electronic world as well too. So there's still a little bit of confusion and complexities going on there, but again, we're making progress. HIMSS here, and I've listed the link in this slide, has also developed through its Quality Patient Safety Council a document to give eMeasure guidance on developing eMeasures and implementing eMeasures as well. Also, what the HIMSS board did back in January of 2012 is sent a letter to Health and Human Services and Dr. Kathleen Sebelius outlining recommendations to improve eMeasure development and implementation processes, trying to reflect the concerns, the challenges of measure developers, the vendors, and the providers. So recently, in fact, at the annual NQF meeting, where we hosted a panel on eMeasures that represented the developers, vendor, and the providers, we actually talked a great deal about this. So the document, again, I have the link here, and I would encourage you sometime to go get the document. It is an excellent read. There's a lot of other information behind each of these 9 recommendations. A couple that I want to mention here today. Of course, is the development of a library of standardized endorsed value sets to be used by measure developers when creating, retooling, and endorsing measures. That we must really, truly create that standardization, and it must be a library that is accessible to all. And improve the process for publication, maintenance, and updating of eMeasure specifications. And what HIMSS is really recommending there, again, with input from its membership and discussions with vendors and developers and providers, is that from time of publication of these measures for eMeasures, that there needs to be an 18-month lead time, because it's going to take that amount of time for vendors to be able to consume the the measure within their solutions and their EHRs, and then to be working with the actual providers and their customers to actually implement into a live environment. Also a recommendation on development of an eMeasure endorsement process and require eMeasure endorsement for all future clinical quality measures, and that eMeasure should not be endorsed or should not be published unless they are NQF endorsed. So that was a very strong recommendation as well too. Again, I'm not going to read through all of these, but that require eMeasure pilot and field testing of all eMeasure specifications. There is a lot more, I think, initiative and collaboration going on here today, and we'll see more in the future between the developers and the vendors, as the developers are going through their rigor of developing these measures and getting them into the measuring authoring tool, and that it is required that they do a certain amount of testing. And whereas in the past, testing was not required necessarily in the EHR environment, I mean, the recommendation is moving forward is that we need to do field testing before this is ever really published as a required and NQF endorsed measure. I think overall a lot of the industry agrees with that, so we'll see where this goes here in the future. And then, of course, harmonization, that pops up again, that harmonizing the use of clinical and financial code sets, that we need to create that alignment and harmonize those various code sets between the clinical and the financial. Okay. So CMS, also then last week, Dr. Kate Goodwin, as she's giving this kind of a State of the Union with CMS and quality reporting, talked about some of their next steps for eMeasure reporting. And what I read through this is that this letter, then the slide that I previously showed you from HIMSS to CMS to HHS is being received and heard, because I can see some of this coming out in terms of CMS's next steps. One, CMS, I think, is totally starting to embrace this whole concept of the measuring authoring tool to create eMeasures, and also the quality data model. Again, understanding the quality data model is not perfect, and there's still refinement that needs to occur, and that is still reviewed on an annual basis, and then it's actually then put out for public comment as the model is reviewed or any changes are made as well too. And then I know the CMS is not listed here on the slide, but is also developing or has developed, again, an eMeasures guide document, again, for developers and vendors and providers, and trying to provide more support through CMS too, particularly for quality measures as related to meaningful use. And including then too pilot testing transmission on specifications, that as the eMeasure specs are defined, determined, that there is pilot testing again in the field, and also then to include the EHR vendor. Okay, so now I'm going to do a little bit of a switch over to some other initiatives about innovations in model of care. So CMS, part of some of their other activities out there beyond, again, meaningful use and just general quality measures focus, is looking at, so where do we, or what do we need to be doing here in the future in this country to achieve these goals around the national quality strategies? We know that the models of care need to change. How do they need to change? What are the innovations? What are the technologies that need to support this in a very different way that thinks beyond the walls of the hospital and the provider offices? So again, I think as I went out to the website on the Innovation Center, which, you know, I don't know if all of you are, but I'm on the weekly kind of update from CMS and HHS, or sometimes I feel like it's daily, in terms of what's coming out with various innovations and some of the CMS activities. But I think that there's something like 13 different categories right now in terms of innovation initiatives that range all the way from the patient-centered medical home to actually long-term care. There's some in the maternal child area. So a lot of various different initiatives as related to innovation and how technologies can support and, you know, what are people doing out there? And I think so some of what we saw Dr. Cantor actually present here today as well fits very, very nicely into the Innovation Center. One of the other programs that's out there by CM or HHS that has been funded is the Beacon Community Program, and these also are considered part of the Innovation Center. And it's really this is a strategy to really strengthen healthcare IT initiatives and the infrastructure to really support exchange and to really support care coordination and improve quality, and across the systems, or across the care community, I should say. So right now there are 17 Beacon communities. They're doing some awesome things in some of these various models. I know that we have one here in San Diego, and it's really exciting to see some, again, of what's coming out of the various Beacon communities. So again, just wanted to kind of keep your eye on, or if you hear that term, you'll know something about it. Another initiative, of course, is moving into accountable care organizations. And first, I always like to talk about accountable care. And in my mind, there's a very distinct difference, is that accountable care is what we're trying to achieve, and the model of an ACO, I think, is going to change, and how those models are looking today, we can expect are going to look very different in the future. But again, accountable care is about hospitals and physicians and patients and payers and employers that are incentivized to really work together to achieve quality patient safety goals and also decrease costs. Okay? The models that are out there do not require necessarily a beneficiary lock-in, and that these new models include things such as shared savings, capitation, bundled payments, but there are penalties for not meeting quality and cost benchmarks. Also, the models also vary in the amount of risk and reward. So if there's more risk, there tends to be more reward. And again, I think that there's more information out there if you'd like to review about what are the models that are currently underway, who are the pioneer ACOs, what are some of the bundled payment initiatives that are going on. But I think it's of interest to try to keep up with, at least to some level. So CMS announced their final rule on ACOs for their payment model and quality measures. It was last fall, I believe it was. And in that final rule is included 33 quality measures across 4 domains of care. And the model actually relies very heavily on local accountability, shared savings that we've already mentioned, and again, the performance measurement. And I think I've sort of alluded to this, that ACOs are really a structure for other reforms as related to the shared savings, bundled payments, full and partial capitation, patient-centered medical home, quality and performance measurement, but we can expect that healthcare IT and actually analytics is going to be foundation to all of these in order to achieve. And again, meaningful use capabilities are foundational to achieving accountable care. So all this work we're doing right now with meaningful use, I think that we're going to see just expand to really support accountable care as we move forward as well. The last area that I want to talk about is really informatics, and specifically, I think, to the clinicians and informaticians here in the room, and for you that are not informaticians or clinical informaticians, to understand kind of the support and the importance of clinical informatics as we move forward. I would say that informatics, again, is in the eye of the storm, but I say a perfect storm because this is really our opportunity to make a difference. And often I'm using this in the context of nursing informatics, but again, as Willa said in her presentation, we can really apply this across probably all clinical domains, whether physician, nursing, pharmacist, or others. Also, too, I often will use just a follow-up slide with this same kind of format showing informatics in the center, but I changed the public policy and some of the industry pressures to incorporating that, including that we need to be thinking about informatics in the context of not only clinical practice and education and public policy and leadership, but also research as well too, and that the research arm becomes very, very important as related to comparative effectiveness. So thinking about informatics today and tomorrow, and it's really, again, thinking about informatics as an extension of clinical practice or an extension of the research arm. and defining those clinical competencies that are needed based upon the role type and what is trying to be achieved. I mean, I will say for myself, I don't consider myself in the purest form a clinical informatician, but I am at some level. And I need to understand what are the IT and the informatics competencies that I need in my role in order to be successful in the various initiatives and healthcare transformation that I am engaging with. The informatics folks, very important, particularly here on the hospital side, to build that infrastructure for evidence-based practice, defining the unique contributions that clinical informatics makes through taxonomies to the information model and transformational care. Also partnering for workforce readiness development. I mean, we heard through Willa in terms of her study, and that really preparing that workforce for an implementation, CPOE or other, is very, very important for successful adoption. Educating organizations about informatics. I think organizations are becoming more educated, but there's still work to be done. And really being the leaders out there too about communicating, sustaining the vision about where is it that we're going, where do we need to be, and how is technology and informatics and innovations going to help us get there. Partnering with our C-suite members who should be focused on similar long-term vision and strategies for the organization. Incorporating human factors concept and usability for transforming care delivery. We know that one of the major reasons for lack of adoption is because we have not really considered as much as we need to the human interface and the usability aspects of a system. So an area that we need to continue to work on and really partner with our various vendors as well. And then supporting and optimizing evolving care delivery models. This is where we are today. Where do we need to be in the future? How do those models need to change? And how are we actually going to change those? And the last bullet is blend business and clinical intelligence and analytics. And this really deserves, I think, a slide of its own, because I really see this as the next evolution for informatics. That is going to be very critical to accountable, integrated, coordinated care. That we have to have the right information in the right way to really support informed decision making. It's going to have to extend beyond just the traditional EHR functionality. It's got to be within, across, and beyond provider organizations. Although we need to be able to use the data from the EHR, not only from the revenue cycle, but also from payers, as well too. And it must cross from individuals to populations for population health management. So this is another area too where for HIMSS, for 2012 has formed another committee too on behalf of its membership, is the Clinical Business and Intelligence Committee. So I already mentioned the e-consumer, connecting the consumer committee. Now we have the Clinical Business Intelligence Committee, and the third one, which I don't have here on any of my slides, is the standards and interoperability, because obviously there is, again, strong focus, needs to be continued focus, laser focus on standards and interoperability, and something that for stage 2 and meaningful use with the ONC is definitely very heads down on with their NPRM. So my last slide, and I will wrap this up. While we will continue to manage a certain amount of uncertainty and complexity, there are areas where we need to continue focus, and that is obviously the national quality goals and the delivery system reform drivers. And again, I think the national quality strategy and those goals gives us that opportunity for all of us across the industry, regardless of our role and what perspectives we're coming from, to rally and have one central focus point in terms of how do we achieve these goals. The shift from the volume to value-based reimbursement, it's hard right now to change some of our care delivery models, particularly as related to accountable care, when the current, financial systems and reimbursement systems, payment models do not necessarily support those changes. But that will occur, so we just have to keep at it. Consumer and patient engagement emphasis. Understanding that one size will not fit all with accountable care. Again, I think that the models that we're seeing, that is demonstration models and the pioneer models today, good start, but we can expect those will change in the future. Buzzwords will probably continue to change, but I think some of the requirements and tools will be more defined and sustainable in the future. And the last point is that change management is very, very critical. And we know that change is hard, but it is something that we need to understand, and we need to figure out ways to manage that for success as well. So again, thank you. Thank you for letting me impart this information to you, and I'll stop there for any questions.
Do we have some questions? Everybody wants lunch, I think. What? Oh, good. Right behind you.
The common language that you're speaking of, are you talking IEC 9 or 10, or is that what you're alluding to?
That definitely has.
Have they even decided what they're going to use, 9 or 10?
Well, I think right now we have a delay. We have a delay in ICD 10, and I think we're waiting for final rule on that for CMS. Someone may have an update on that more than I do, but that,
Even vendor to vendor with the different descriptions of stuff. Even.
yes.
Yeah.
There's, as we say, lots of opportunity for standardization out there.
Dana,
Yes.
Dale Sanders.
Oh, hi, Dale.
Thanks, very nice presentation. I'd like to hear your comments about the GE side of your life and what's going on with GE and healthcare, and maybe even comment on the Amalga and
Okay, sure.
Caredigm and all that.
Well, first off, a few years ago, before the National Quality Strategy was released, GE released kind of part of its initiative called Healthy Imagination, and some of you may have heard about that, and I know it was released around the time of the Olympics. And what was very interesting to me is that Healthy Imagination focused on better health, access to care, as we've stated, and then decreasing cost. So then when the National Quality Strategy came out with the triple aim, it was like, wow, is this, I mean, how do we have insight, like insider trading on this or what? So it makes me feel good as an employee of GE Healthcare that we are very much aligned within GE in terms of with the National Quality Strategy. And again, for us, it's about through our healthcare IT, or through our devices, or through some of our service solutions, how can we support our customers in achieving these goals around the National Quality Strategy. So, I mean, GE Healthcare and Healthcare IT is very much committed to that. Now, how they play now and how they play in the future, probably can expect changes. I'm being told I'm done, by the way. We can expect some changes. One change that is occurring, and some of you may be aware of this because it has been announced, is that GE and Microsoft is forming a joint venture company called Caredigm. And so they're taking some of the products and solutions from both of the companies and combining them into a new company that is really going to be focusing on this clinical data analytics aspects, providing surveillance, tools for hospital readmissions and preventing those, also doing quick rapid response. So a whole host of various solutions that are going to be here, that are here today, and then more that is coming in the future related to the development work that GE has been engaged with Intermountain Healthcare over the past 5 years as well too, related to, again, clinical data analytics and so forth. So there's a lot yet to, I think, to unfold in that area. Thank you, Dale.
All right.
Okay, thank you.
Thank you, Dana. Just a really quick announcement before we break for lunch. On the third floor, there's a patio. If you take the elevator up, second right, and go out the door and you'll be on the patio.